isopropyl, by adding 2 more methyls, and they found that this compound just had much, much more affinity than either of these other 2 compounds for beta receptors. And this is actually isoprel. So if you look in your book, you have norepi, epi, and in terms of beta receptor, this has the most beta receptor sensitivity. This is next, and this is least, okay? And there's a picture on your book, and this is actually the kind of thing that comes up on board exams too, but on page 72, you basically see this as sensitivity to beta receptors at the bottom. Isoprel is greater than epi, which is greater than norepi. And with respect to alpha receptors, it's different. The beta receptors is very important here. Okay.
What's that third word up there again?
Proterenol.
Proterenol.
It's isoprel.
Oh.
Okay. In the late 1950s, there were pharmacologists that, around the world. There's a guy who won a Nobel Prize for just making modifications to this. But Eli Lilly said, well, what if we take this compound here, which has like really, really high affinity to beta receptors, and we just change it. Instead of putting hydroxyl groups here, we put 2 chloride groups here. What happens to it? Well, what happens is that this will bind beta receptors, so it has affinity, but it has 0 intrinsic activity. So what would that do? It blocked the beta receptor. Now, I mean, this it turns out it was like a poison you can give people, but it was a beta blocker. They started thinking on this. There's a guy, James Black, who won the Nobel Prize for making propranolol. And what he did, he basically said, we know that isoprel, if we're talking about drugs that stimulate beta receptors, you want to have, if you're going to start out with drugs, you want to start out with the ones that have the most affinity to beta receptors, right? So that they started out with this part of isoprel because it had so much affinity to beta receptors that it bound very strongly to it. And they modified this part to make drugs that would bind to beta receptors but have no intrinsic activity, and they ended up making beta blockers. Okay, and if you look at, is there any place that has structures of beta blockers on? I'm not sure. Anyway, if you look at the structure of beta blockers, they all have this part of isoproterenol. Almost all of them have this part of isoproterenol in their structure, and this part of it's different. So this binds to the receptor, and the changes here keep it from activating the receptor. It makes it block it, and that's where beta blockers come from. So beta, you make a very strong beta agonist by increasing the methyl groups here, and then by changing this part of it, you can actually have a drug that binds to the receptor, has very, very high affinity, but no intrinsic activity, and you get a beta blocker. Okay?
So isoprel has no intrinsic activity
No,
either?
no, isoprel is a beta agonist.
Okay.
Yeah, isoprel is the most. Isoprel will be the best at increasing your heart rate and increasing contractility, but the the thinking, I mean, it was kind of logical. They were looking and they said, well, if adding a methyl group makes it better, adding 2 methyl groups or more makes it better, and they found out that was. And then they started playing with the compound. There was something they called structure-activity relationships, and said, well, we know this is responsible for getting to the receptor. Maybe we can change this in a way that blocks the receptor. And it turns out probably one of the most significant discoveries, in the last 100 years was, propranolol, the first blocker. The guy, Dr. Black, made the first antihistamine, H2 blocker when he made cimetidine next. But he didn't. It changed medicine dramatically. But if you your standpoint, know that isoprel is the greatest beta blocker, highest sensitivity, followed by epi, followed by least is norepi.
Excuse me, I'm just confused.
Okay.
So this isoprene is supposed to be working higher than 80, right?
Right.
Because it has two more methyl groups.
Right.
So to block it.
And what they did is, first they made a drug, which is like an extremely good beta agonist, much better than epi. And then they changed that drug. They said, wow, for the beta blockers, we're going to start out with this drug and make big changes to it and come up with a whole different class. But this drug right here is a very good beta agonist. Of the ones we have, it's the one that's the strongest at stimulating beta receptors.
What is a blocker?
Yeah, if you change it, what they did, first they made this, and they found they had a beta agonist, and then based on this drug, they made a whole group of drugs that were similar in some ways, different in other ways, but they were all based on this drug that were the beta blockers. So this is not a beta blocker.
Okay.
Propyl group gives a high affinity for the beta.
Right.
And it gives receptors.
Now the other thing that they found is that when you measure the effects on alpha receptors, like if you look at any alpha binding, that this has 0 effects on alpha receptors. So as soon as you do this, you get good beta response, but you lose all its alpha. And if you look at alpha, for alpha, alpha is really bad. I mean, it has no alpha effects. Okay, so if you give this to someone, they're going to get vasoconstriction and vasodilation. Their arterioles will dilate. You get some alpha beta effects. If you give this, you just get the dilation of your arteriole, but you don't get any alpha effects. So you get tachycardia, increased heart rate, but you're going to get vasodilation. Your blood pressure will go down. Your SBR will go down. There's some graphs that show the blood pressure response to these drugs, and you're not going to. There's no picture. None of those graphs are going to be on the test. Okay. So it makes sense. They looked at 2 drugs. They said this one's a better beta. Based on that, we'll change it. They made a much better beta, but as soon as they do that, they lose the alpha. Okay. There's another drug. Okay, so this is epinephrine here. What other people thought is, well, what if we change this part of the drug a little bit? And what they did is that they took, this is epinephrine, and they took off this hydroxyl group here. Now they have a drug that has 0 beta effects and is a pure alpha effect. It still is good alpha, but no beta. So are you following? I mean, is this anybody not seeing like how it goes together? So if you give this drug, what would you expect it to be? I mean, what would you expect to see with that? Yeah, you squeeze the precapillary sphincters. What would happen to preload? It would go up, blood pressure would go up, filling pressures would go up, and SBR would go up. And this drug is phenylephrine, Neo. Okay, So the only difference between phenylephrine and epi is one oxygen molecule. Like, here's a hydrogen here, so that one oxygen molecule is the only difference between neo and epi, okay? Now, so neo is pure alpha, very good alpha drug, no beta. Is this a catechol? No. So because it's not a catechol, what do you think that means? Like, how's this metabolized? If you give someone epi, how's it metabolized? Calmed. The catechol low methyl, it puts a methyl group here, right? But since this is not a catechol, COMT doesn't metabolize it. So, so the clearance of this is going to be much less than the clearance of this. So what do you expect the duration of action of that to be? If the clearance of this is less, then the duration of action would be longer, right? So when you give neo, you can give it by bolus. Usually you give this by infusion unless it's a code. But this you can give a bolus and it lasts a long time. And the key difference is that it's not a catechol. Remember, COMT is intracellular or extracellular? Extra. And so while it's circulating, COMT is chewing up epinephrine and metabolizing it to an inactive drug that gets excreted in the urine, but it's not metabolized here. Okay? So the difference between neo, phenylephrine, and epi is not a catechol. It's only one oxygen, one molecule difference between these two drugs. But it changes the whole receptors. It takes away all its beta effects, and it still makes it a good alpha receptor agonist. And it increases the duration of action because it has an entirely different metabolism because it's not a catechol, right? This is why I drew the catechol right in front of you a while ago.
So what breaks it down?
It gets broken down, like the liver will break it down, and they're non-specific, like oxidative pathways, other places, but it's not nearly as efficient as a COMT.
And all these drugs are still non-polar, right?
They're all what?
They're all non-polar drugs, they're across the blood-brain barrier.
Yeah, this is, yeah, it can be polar. This is pretty polar here. This becomes less polar when these can have charges by putting this aromatic thing on hydroxyl here, it becomes less polar here. So, but yeah, this is probably the big place. This can go to become a quaternary amine, be positive charged. And so all the drugs, dopamine, phenylephrine, isoprel, epi, norepi, they all have different sensitivity to alpha and beta receptors. Dobutamine is what? If you had to call dobutamine, what would you say? So what kind of agonist? Beta, what? 1 or 2? Where's the beta? Which ones are in the heart? 1. Heart and kidneys. So beta 1 agonist. Okay, beta 2 would be in the arterioles. Okay, so dobutamine is a beta 1 agonist. Phenylephrine neo is a alpha 1 agonist. This is alpha 1 receptor. Dopamine is mainly a dopamine agonist, but it has some at high doses it can give you beta, and at really high doses it can give you alpha effects. Isoproterenol is a beta 1 and beta 2 agonist. Epi is alpha 1, alpha 2, beta 1, beta 2, and so is norepi. Okay. There's an alpha 2 receptor here that can be stimulated. So when norepi levels are high here, just in the same way we talked about the cholinergic receptor being stimulated, muscarinic receptors that are presynaptic. They're presynaptic alpha 2 receptors. Remember, this is a beta 1 in the heart. We're talking beta 1. This is an alpha 2, and the alpha 2 release of norepinephrine. So if you give an alpha-2 agonist to someone, what happens to their norepi production? Okay, what would happen to their heart rate? Blood pressure?
Goes down.
Yeah. Do you know an alpha-2 agonist that you use? Precedex, dexmedetomidine, and clonidine. So, Precedex, dexmedetomidine is an IV form, and clonidine is a PO form that is used to treat hypertension. All these have central effects too. They can give you sedation. There's alpha-2 receptors in the brain where your level of consciousness is affected by the amount of norepi, and in the brain you have less norepi, you get sedation, and that's how clonidine and Precedex give you sedation. But in the heart, it gives you decreased catechol. Now, everybody on the test, everybody gets this confused because you start thinking alpha-2 agonists, in general you think agonists increase blood pressure and adrenergic antagonists block it, but this is the opposite. So the key way you get tripped up is to forget, if someone asks you, is dexmedetomidine or clonidine an alpha-2 agonist or antagonist, a lot of people, either they don't get that concept or they get tripped up by questions on that, but that's important concept. So if you give someone either of these two, blood pressure, heart rate, catecholamine production goes down. This would be like a sympatholytic response, or I don't know another word. It basically reduces your sympathetic tone by giving these drugs here. This is used for hypertension. This is used for sedation because of central effects, and because it's not a narcotic, it doesn't give you respiratory depression. It's convenient for people who have lung disease, COPD patients. There's some other drugs that are in your book, and I'm just going to mention them here. Aldimet. Remember we had DOPA is DOPA is this compound here. If this is the alpha carbon here, if you put a methyl group here, you get alpha methyl dopa, and alpha methyl dopa is aldimet, or methyl dopa. But this drug is very similar to DOPA. So, it's basically one molecule different away from DOPA. So what happens is that it gets converted to dopamine as not a real dopamine, but a methyl dopamine, and then it gets converted to something like norepinephrine. It gets produced and it gets released, and it actually has strong alpha-2 agonist effect. So Aldimet, which is alpha-methyl dopa, or Aldimet, is a relative of dopa. It has this methyl group on the alpha carbon. It gets taken up, metabolized, removed, eliminated. It doesn't do anything here, but it feedback and it inhibits further release of catecholamine. So this is kind of a different type. These drugs here, you give them and they stimulate the alpha-2 receptor directly. This one is metabolized and forms a product that stimulates the alpha-2 receptor. And this is a drug that's been used for what? For what? No, not methyl dopa. L-dopa is Parkinson's, which is going to be the next talk in a few minutes. This is used for hypertension. It's like one of the early hypertensive drugs. So all these drugs, like people in the NIH in the 1960s were just making drugs, giving it to, putting it in animals and just looking at effects. I know the man who actually discovered this drug that Dr. John Oates was working in. I got to meet him here to story about that. But, they were just trying like lots of different drugs, looking what they did, and they just made different modifications of these various compounds here. Okay. Other drugs that are important. There's we're going to talk about the brain dopamine receptors. There's in the brain, there are dopamine 2 receptors. In the periphery, there are dopamine 1 receptors. There's a picture here of I think it's for the Parkinson drugs. The Parkinson drugs, there's going to be a picture of dopamine actions in the body, but in the periphery we have dopamine 1 receptor, in the brain we have dopamine 2 receptors. Dopamine 1 receptors, when you give renal dose dopamine, you're stimulating dopamine 1 receptors, and what does renal dose dopamine do? It increases renal blood flow and it gives you vasodilation. So basically you get vasodilation and you get stimulation of dopamine 1 receptors. You can do it with low dose dopamine, or you can do it with phenoldiprine. What's the other, what's the other word for phenoldiprine? Chloroquine. Okay, so it's a dopamine 1 agonist, so it stimulates dopamine 1 receptors, and these receptors are different than the alpha and beta receptors we're talking about. But there's only one drug we're really interested here, the phenoldiprine. Many of the side effects of the Parkinson drugs are related to dopamine, but phenoldiprine is, what's it used for? For what? Yeah, and who would you like to use phenoldiprine for? Like someone with kidney problems, because it actually helps renal perfusion. So if you have someone who has like a creatinine of 2 or 3 and you're worried about, hurting their kidney function, it's a good, if they're hypertensive, it's a good drug for someone with like renal issues. So other drugs, we have phenoldiprine. There are beta agonists that are in the book, albuterol and terbutaline. These are short-acting beta-2 agonists, and then there's long-acting beta-2 agonists that are used for asthma. So these are long-acting beta-2 agonists. So in the book, there are a lot of drugs that talk about, these are the ones you should, that might be on the test that you should pay attention to. The Precedex, dexmedetomidine, clonidine, which is Klonopin, what am I thinking?
Catapress.
Yeah, Catapress. Alpha-methyl dopa, which is aldamet, phenoldiprine, albuterol and terbutaline, short-acting beta-2 drugs, salmeterol and formoterol, which are long-acting beta-2 drugs. We'll get these when we talk about treatment of asthma. So these are all the agonists that we'll talk about. Any questions about these? No? Okay. Yeah, it's a dopamine one. I just have it there. That's a list of the drugs that we are going to be, from this chapter, to pay attention to.
What about albuterol and
Those are beta. Okay, now let's talk about alpha blockers. Okay, there's three types of alpha blockers. There's irreversible. These are in the book. So there's three different kinds of alpha blockers. There's an alpha blocker called phenoxybenzamine that irreversibly binds to alpha 1 and alpha 2 receptors, and it's there forever. There's a reversible alpha 1 and alpha 2 blocker, phentolamine, and then there's most alpha blockers that we use. This is Regitine. I don't know where you places where they use Regitine. And then there's alpha 1. Most alpha blockers we're talking about are these drugs here. Prazosin is used for hypertension. How would it treat hypertension? Where are the alpha 1 receptors it's blocking? The precapillary sphincters, and what would it do to afterload?
Increase it.
It would decrease afterload.
Decrease it because it's blocking.
Right. Decrease SVR, decrease afterload. And these drugs are used for BPH. It was found that prazosin was helpful in people who had BPH, and by blocking alpha 2 receptors on the in the bladder, you can help people with BPH who have symptoms of prostatism. So basically,
Alpha 2 or alpha 1?
alpha 1. Okay, there is an alpha. Here's one alpha 2. If you give an alpha 2 blocker, what effect would you see?
Bronchoconstriction.
What would happen? Would it increase or decrease catecholamine production? It would increase it. So if you block this, you get increased catecholamine production. So this is a drug that is used for, it's an over-the-counter drug that's available for like erectile dysfunction. It's also some, you'll see it in like some over-the-counter preparations for, but it's called yohimbine. It's in the book Yohimbine.
Isn't that a derivative of pot, something like that?
I don't know where, it's a naturally occurring compound. I don't know where it
Yeah.
comes from, but
Not commercially
But-
available.
as far as alpha blockers go, know that these two drugs are good for people with BPH. Know that prazosin is going to be an alpha 1 blocker, and it's going to act on precapillary sphincters. It's going to give you decreased SVR. Know phentolamine is a reversible alpha 1, alpha 2 blocker. There are times where you might use that. Phenoxybenzamine, the only time I've seen this used is like in pheochromocytoma, where you have people who have like really severe hypertension, you want to block them really low. It's really not used that much, but it's an important drug to be aware of. And yohimbine is the opposite of clonidine, and dexmedetomidine is an alpha 2 antagonist. Okay, and it has just if someone comes in on it, you might need to, if they're taking this over the counter, you might need to be aware of it. It's not really going to have a big impact on your practice. Questions about that? Okay, the fate. Excuse me. What? can be. It's an over-the-counter, yeah, it's like an herbal preparation. People use it for erectile dysfunction, they use it for, like, you'll find the different, the main thing is like for ED, before there was, Viagra, this was probably bigger, I've never, used it. It's important to know, how it works, people come across it, just to understand. Now, if it works right here, the receptors by blocking them.
So what?
Okay, we're gonna wrap up, beta blockers. I'm gonna be done with this chapter here. Let me go to, so chapter 7. In chapter 6, there's a big table on, page 84. The key thing that shows you all of where the beta receptors are. Just the key thing in that table is beta 1 is in the heart and kidneys, renin release, and inotropy, chronotropy, and cardiac conduction, and every place else is beta 2. And I don't really, there are no test questions on glycogenolysis or insulin production or that. Just the GI tract, the eye muscle, uterus is important. Terbutaline is used in OB for what?
To stop contractions for premature.
And how does it work?
Oh, that's a good question.
It's
Because I took note of it, but we were studying.
It's a beta 2 agonist.
Okay, oh gosh,
Okay.
I don't think I can, at this point.
Okay, well, it's a beta 2 agonist, and there are, if you look at this chart on page 84, there are beta 2 receptors on muscles that will cause uterine relaxation. So this is useful for like, if someone's going into labor and you want to stop their labor, if they're having contractions, you give them terbutaline to make them stop. Albuterol is used for asthma. These are short-acting beta 2, long-acting beta 2 that are used for asthma. But pay attention to just the big idea is beta 1 is heart and kidneys. Okay. Now on page 97, there's a table with beta blockers, and propranolol is a unique drug. Propranolol is a beta 1 beta 2 and blocker. Propranolol has something that some beta blockers don't. It has membrane stabilizing effects. This is kind of like a local anesthetic. Local anesthetics have membrane stabilizing effects, but because of the membrane stabilizing effects and the fact propranolol, which was the first clinically useful beta blocker, that dichloro, whatever it was, isoproterenol, was never approved for humans. But the next drug was propranolol, and it's like a landmark drug. And the reason it's still around is it has some unique properties. So it's a non-specific beta 1, beta 2 blocker, but this gives it some benefit in certain diseases that other beta blockers don't work in. It's good for MIs, acute MIs, propranolol works well, and it's also very good for people with migraines. It doesn't treat migraines that occur, but you can treat people with prophylactic doses of propranolol that will reduce the incidence of migraines. So propranolol, if you look at the table on page 97, all of these drugs, all beta 1 drugs, will be useful for hypertension. Remember, kidneys and heart would be the one hypertension. So any beta 1 blocker is good for hypertension. For angina, MI, and migraines, propranolol is useful because of its membrane stabilizing effects. It's mentioned there that it's good for hyperthyroidism. If you have someone who comes in thyroid storm, you can give them propranolol, and you give it until, like, they'll come in real tachycardic, and you basically give them big doses, 15, 20 milligrams of propranolol, which is like kind of a milligram per vial. So you're giving like large amounts of propranolol, and you give it until their heart rate's in the 80s, and then you stop. But it's good for hyperthyroidism. But the key thing about propranolol is it's beta 1, beta 2, and then it has something different, this membrane stabilizing effect, which makes it especially good for angina and migraines. Okay. So propranolol, if you look here, this is broken up into several classes of drugs, and propranolol kind of has its own class because of these membrane stabilizing effects. There's two drugs at the bottom I want to talk about. There's carvedilol, is Coreg, labetalol is Trandate. This has so these drugs are unique in that they block beta 1 and beta 2 receptors, but they also block alpha 1 receptors. So what would be the effects of labetalol or carvedilol? You get low heart rate. Like if you were monitoring someone's vital signs, what would you see? Blood pressure go down, heart rate go down, and cardiac output goes down. And this is giving you some vasodilator effects. So you're getting like some of the effects that prazosin was giving you. So you get alpha 1 blockade. So it's a vasodilator and a beta blocker. And when we talk about hypertension, we'll talk about why this is useful, but it's good. Often if you give someone a vasodilator, a young person will often get a reflex tachycardia. So you'll often give like a vasodilator plus a beta blocker. And these drugs have a beta blocker and vasodilator combined. So they give you good effects, and it's good for hypertension. Coreg is useful for people with CHF. It's often given to people who have CHF. You'll find like EFs of less than 30, they may be indicated to get Coreg for that. So the bottom two drugs are there. There's two other drugs here. I'm going to talk about the last. There's Timolol is a drug that Nadolol or they're just not specific. Okay, I want to talk on this. There's two other types of drugs you need to know. One are cardiac or will this be beta 1 or beta 2? So these drugs are give you cardiac effects without giving you the beta 2 blockade. Where would beta 2 blockade hurt you? Like what kind of patient?
Asthmatic.
Yeah, an asthmatic, because when you give a beta 2 blocker, what would happen?
Bronchoconstriction.
Yeah, you could get bronchoconstriction. So if you have, this would give you beta 1 effect, so it would block beta receptors where? Heart and the kidneys. And what in the kidneys, what do beta receptor stimulation, beta 1 stimulation there causes what hormone to go up?
Renin.
Renin, so you get less renin production. So you get This is good for hypertension and tachycardia, okay? And the last two drugs are, this is a new concept. These, and this is different, a little different than both, but I think, you know, if you break these beta blockers down into these groups, you know, these are the important groups. There's the non-specific ones. There's the alpha beta blockers, which are only 2. There's a 4 cardiac selective. There's actually several others, but we're only going to stick to the 4 in the book. And there's a partial agonist. So an agonist at a receptor does what?
Stimulates.
It has affinity for the receptor and it has intrinsic activity. An antagonist, what? Intrinsic activity. What if you had a drug that had affinity but a tiny bit of intrinsic activity? So if you give someone a beta blocker, you get decreasing heart rate, decreasing cardiac output, and then when they're under stress, they're blocked to the effects of their endogenous catecholamines. But if you had a drug that had a little bit of intrinsic activity, just a tiny bit less than they would, not, if you measured our intrinsic activity right now, let's say it's here, beta blocker that's completely beta blocker would get you down to 0, and something with a little bit of intrinsic activity would reduce you somewhere between where you're at and 0. So it gives you so for this, it gives you affinity, binds to the receptor, but it doesn't block it completely. It blocks it almost all the way, but not all the way. And if you look at these two drugs, pindolol and acebutolol, they're useful with people who bradycardia might be a concern, or reducing their cardiac output too much. You'll keep your heart rate, like if they're, just to pick numbers, let's say your heart rate's 90. With propranolol, it might go down to 40 or 50. With these drugs here, it might just go down to 60 or 70 because this has a little bit of intrinsic activity. So there might be some people who can't tolerate a pure beta blocker who can be better managed with these partial agonists, these two drugs here. Okay. If you graft it, if you look at the response, like a beta agonist, let's say you're just checking like a heart rate response. Low doses don't do anything, and then you get dose, and then you get a maximum effect. With an antagonist, you get 0, and with a partial agonist, it would give you something in between. So it has some intrinsic activity and affinity. And just be aware, they don't, I don't know why they don't put pindolol there. Somewhere there, there it is on page 895, they put it together. Antagonist with partial agonist activity. This book is not really great with the muscle relaxants or with the beta blockers, but this is the general concept of the beta blockers, that they can be characterized by whether they have membrane stabilizing effects, whether they're not selective beta 1, beta 2, or they're selective, there's 2 which are special because they're not selective, alpha 1, and then there's 2 that are partial agonists, okay? And the other ones that we didn't talk about, like the timolol, navolol, they're all non-selective. They're beta 1, beta 2. Any questions about beta blockers? No?
Acebutolol is both beta 1 selective and a weak or partial agonist, right? Both of those.
did I write wrong? Alcohol. Yeah, acetyl right here. Okay, we're gonna finish with neurodegenerative diseases, which is remarkably and sadly similar to all the other stuff we've been talking about here. More chemistry here. I have a handout that, I made 25 for this stuff. You guys, that's it.
Just a quick question, on the test, it's all
Sure.
generic names?
Yeah, no.
Because you
yeah,
mentioned
no.
some trade names.
Yeah, all generic names, I don't even know all the trade names. What's weird is if you read the literature, like if you read, like in other countries, they call drugs with different names, so, I mean, if you start reading trade names, you get really confused. You're giving them, all right. So, so here's what we have. We have the pathway that catecholamines are made. We have tyrosine going to L-DOPA by the enzyme tyrosine hydroxylase. And then you have dopa decarboxylase, which is, you'll see aromatic amino acid decarboxylase or dopa decarboxylase that takes this off and makes dopamine. And then you have dopamine beta hydroxylase that makes epi. So these are 4 compounds. Which of these 4 compounds are amino acids? Tyrosine is one. There's one more. Dopa is another amino acid, right? You see, this is not an amino acid, right? And this is not an amino acid because it has to have COA and COA amino acid. Now, the blood-brain barrier, none of these drugs are naturally going to diffuse across the blood-brain barrier, okay? There are transport proteins here that will transport amino acids into the blood-brain barrier because the brain needs amino acids to make neurotransmitters and proteins, right? So, so if you have someone who has Parkinson's disease, and Parkinson's disease is a deficiency of what? Dopamine in the brain, basal ganglia, right? So if you, let's say you have a guy who has Parkinson's or a lady that has Parkinson's comes in and they have an IV, can you give them dopamine to treat their Parkinson's disease? No, because there's no way, the brain doesn't need to have dopamine, and it's not going to diffuse across, and it's not going to, there's no transport way to get it across. So you can't give that person IV dopamine, okay? What if you give them IV, what if you give this person, anybody, tyrosine, will you make more dopamine if you give people, like if I gave people a massive amount of tyrosine, will you make more dopamine here? Why? Yeah, well, I mean, the cells that make it aren't gonna make it because this enzyme's gonna regulate it, okay? Whereas if you give your patient L-DOPA, what happens is that all the L-DOPA immediately gets converted to dopamine, and if the cell makes it, it'll go to norepi, okay? So once you get past this rate-limiting enzyme, you can give it. So you can't give someone with Parkinson's tyrosine just because in the same way as like when you eat like a big protein meal, you have a big steak, you're not gonna make a lot of dopamine, because it's regulated here. But if you give someone DOPA, then they will make a lot of dopamine, okay? Because you bypass this rate-limiting enzyme. So does that make sense?
Mhm.
Okay, so when we can't give